up to the level of the knee. On the cardiovascular examination, she had a raised JVP with an apex bit displaced at the 6th intercostal space, anterior axillary line. Also had this systolic murmur on the left lower sternal border and a systolic murmur radiating to the axilla. On the respiratory examination, the positive finding was that she had bibasal crepitations, and per abdomen had this tender hepatomegaly. So we worked her up, and these were the results. Had an A1C of 9% with a fasting blood sugar of 9. Also had triglyceride of 2.8 with an LDL of 5.2 and an HDL of 2.1. Total cholesterol elevated at 8.5. Her pro-BNP was also elevated at 600. On ECG, she had sinus rhythm with a heart rate of 75 beats per minute. Also had a wide and broad QRS of more than 160 milliseconds. We did an echo on her. She had an EF of 30% with left ventricular hypertrophy and moderate MR and TR. On chest X-ray, she had a cardiomegaly with a pulmonary congestion. So at this point, we started instituted guideline-directed medical therapy. Started on the sacubitril valsartan and spironolactone. Later on, added bisoprolol 5 milligrams OD and EMPA at 10 milligrams. Also instituted Lasix IV at 40 milligrams. And we continued with the atorvastatin, the junior aspirin, the metformin, sitagliptin, and also invited in our nutritional team and changed her oral hypoglycemic to insulin. So at this point, we want to ask the questions: what are the other considerations for these patients in terms of management, and what are the choices of medications to optimize our glycemic control, given that she's an obese lady, and what is the role of multidisciplinary team in the management of heart disease in type 2 diabetes?
Thank you very much, Dr. Judy. A round of applause for Dr. Judy for her patient. So these are very pertinent questions that we ask ourselves when we are faced with a patient who has heart issues and diabetes. So before we move to our cardiologist, Judy, I'd just like to ask you, what is the thing that struck you? Why did you choose this patient as your case presentation for the day?
I found this patient, this is almost like a typical patient who comes to us, you know, with these comorbidities. They have diabetes, they have hypertension, kidney disease, dyslipidemia. And so in their approach, you know, sometimes we talk from a point of privilege and sometimes from a point of, you know, a low resource setup. So this is a patient who comes at a tertiary facility where the resources are scarce, and probably the subspecialties are not like many. And so I chose this because we see these patients quite a lot, and the time where we invite our subspecialties, probably time has gone so much. And then on the approach of the patient, who are the people to come on board, and at what point do we bring them on board?
Thank you, Dr. Judy. So we'll start with Dr. Wagana. The first question: what do you think are the considerations that you would give this patient in terms of management? How do you start? What's the approach?
Thank you very much. Thank you, Judy, for a very clear presentation. When we look at heart failure, we're thinking of three things. We're thinking of reduction in mortality, we're thinking of preventing hospitalization, and we're thinking of improving quality of life. So everything that we do for the patient should be centered around that. The patient she presented is a bit complicated, especially because of a preceding history of an MI before that. But for all our heart failure patients, in the absence of contraindications, we want to ensure that we have guideline-directed medical therapy, which has a pillar of 4 medications. We heard she had put the patient on sacubitril valsartan. We also want an SGLT2 inhibitor. We want a beta blocker and a mineralocorticoid inhibitor, either spironolactone or eplerenone. And then if there is need, then we add diuretics. In our discussion, we'll go a bit deeper in a black population who is not improving well on heart failure treatment. What other medications can we add? But we should target that all our heart failure patients with reduced ejection fraction should be on those 4 medications.
Thank you very much. Dr. Nguga, would you like to add?
Yeah, thank you, Hilda. And this is really a typical patient we see in the hospital. And I still remember a talk of doctors called hospitalists. So in fact, you wonder who is the best patient to take care of this patient, because this patient had an acute myocardial infarction several years ago and now is suffering from post-MI LV dysfunction. The patient has type 2 diabetes, which is not optimally treated. The patient appears to have very high cholesterol. You have seen a total cholesterol of 7 and an LDL of 5 point something. She didn't mention the patient's BMI of around 30, and the patient is coming with heart failure symptoms. If this patient was to be in the hospital, I can assure you there will be a multitude of doctors who will be involved. And if you are in Aga Khan, you will have a blood gas performed. Could this patient be having obstructive sleep apnea? So there is, in patients with heart failure, we call them non-cardiac comorbidities. What are those things which are not in the heart, which are contributing to this patient's worsening of the heart failure symptoms? Because this patient, it looks like the EF is 30%. It's true there are a few valves which are leaking, but there could be other factors which are contributing to their worsening heart failure. Could it be obstructive sleep apnea, for example? Could this patient be anemic? Okay, the patient also, as we have noted, has a kidney issue, so it is true that as you are treating them, you expect that to kind of keep a close eye on it. So it's a multidisciplinary patient, and I believe we may see even a growth in that field we are calling hospitalists, who are actually kind of embedded in other parts of the world to really take good care of this patient. Another test which will probably go by default in this patient is a troponin. So you want to find out, when you have had a previous myocardial infarction, this is the kind of troponin, cholesterol you are having, then there's a high risk of recurrent events. Could the patient be having recurrent events which are causing them to have symptoms, because the risk factors are not well controlled? So this is really a typical patient who involves multidisciplinary teams, but we do believe there is probably room for multidisciplinary doctors as well.
Thank you very much. Now, in low resource setting, and where we talk about resource, not just infrastructure, but also the manpower, where some of our physicians are actually the cardiologists of their hospitals, what kind of advice would you give them when they're presented with a patient like this?
Thank you, Hilda. You've really thought about this. The four-pronged Fantastic Four for heart failure. I know there are issues with cost of medication, but I think that each of us, and not just perhaps a physician, even our medical officers and clinical officers, need to understand the indications to start the Fantastic Four and to start them early, as opposed to waiting until a patient is a subspecialist, in which case they have gone through a lot of treatment. But in a patient whose ejection fraction is less than 40, we need to start on the 4 medications. If the ejection fraction is above 40, particularly if it is above 40 and less than 50, what we call the mid-range ejection fraction, then the sacubitril valsartan evidence is a little bit less robust, and we can do with an AC inhibitor. If not well tolerated, then we can go for an ARB. But in patients whose ejection fraction is below 40, we should have the confidence, and I hope at the end of this talk we will demystify it enough so that all of us are confident to start, because these are drugs that actually improve LV systolic function, they improve outcomes in heart failure. And a lot of times, many of these patients don't get to the desperate point where they require to see a cardiologist. And even if they do, then they don't go in such a sorry state. And maybe one tip, I think it might come out in my talk, sacubitril valsartan, we now have got generics. One of the tricks that one could use, for example, if you want a patient on 50 milligrams twice a day, you can use the 100 mg tablet, split it in 2. The cost of 1 tablet covers you for an entire day. So you may not be able to do that with a 200 dose, but it helps to reduce.
Those are really good points. Now, before we go to Dr. Wagan, there's a second case we're going to present. But before we go there, Dr. Ngunga, you're a lipid expert. Now, this person has very high cholesterols, very high TGs. All the physicians who are here have been bombarded of late with the new drugs, bempedoic acid, ezetimibe, daktari, write this. The question is, Are these drugs, is there any of them that actually offers a cardiovascular benefit to the patient, or can we just stay with the statin we are used to? Is there any consideration there?
Thank you. When we started medicine, all of us several years ago, we only had very few drugs for treating cholesterol, and by and large, these drugs were statins. By and large, there were a few fibrates here and there, but we are seeing more and more armamentarium of drugs for cholesterol coming up, and indeed they are still not here. We still have many more coming up. So the first line treatment for patients with this kind of problem, cardiovascular disease, this patient falls in the group we call very high risk. They have already had a myocardial infarction, they have type 2 diabetes, they have heart failure, they fall in the very high risk group. That means the treatment should include at least very high, what we call high dose statins, which is atorvastatin 80 milligrams, or indeed rosuvastatin 20 to 40 milligrams, which are actually available in our country as well. In addition, the drug which have been shown to also improve outcomes in these patients is addition of ezetimibe and bempedoic acid. So they should not be given in isolation. First of all, you should give them high dose statins, and in addition to that, then you can add those additional drugs, but they should not be given in isolation. There is an entity, or there are two elements that I have observed in my practice. Number one, doctors who are skeptical about giving high dose statins, and sometimes when you tell the patient we give them high dose statin, they start getting scared. You just tell them this is not a high dose, you just tell them this is the dose that you need. Because at the moment you mention high dose, then they keep walking around reading high dose, then they start seeing all manner of problems. So you just tell them this is the normal dose that you require for your treatment. Then they kind of settle down and they don't go looking, oh, this is high dose and the low dose. No. And I believe by doing so, we shall reduce, make the lives of these patients better by reducing recurrent events, and that's what the evidence is out there. So the physicians themselves should go out of the way to implement those kind of interventions. On the other hand, what we also see is when the cholesterol comes down to 1.4, and the patient is on 80 milligrams of atorvastatin plus ezetimibe, doctors sometimes are like, oh, these medicines are very many. Can we reduce them? Do not reduce them. That is a dose that is required to maintain that patient's LDL at that level. So be happy to encourage your patient to continue this, because the moment you put a doubt on them again, the same problem comes to light. And we believe that that level of cholesterol keeps patients away from the hospitals.
Thank you very much. Now, Dr. Judy, I'd like you to proceed to the second case, and Mark, you will have time for Q&A at the end. So as we continue having our discussions, note your questions so that you can ask them at the very end. Dr. Judy, take the stage.
So our second case scenario is a 58-year-old gentleman who is a subsistence farmer. Comes in with a 2-year progressive history of features of heart failure with reduced ejection fraction. Also has a 4-year history of type 2 diabetes and a 6-year history of systemic hypertension. He has a dual chamber pacemaker implanted 1 year ago. Prior to this presentation for complete heart block, was advised for cardiac resynchronization therapy, but was unable to raise funds for the same. Medications at that time, he was on Lasix 40, spironolactone 25, on dapagliflozin 10, sacubitril valsartan at 50 milligrams BD, metformin 500 BD, and sitagliptin 50 once a day. He presented with frank decompensation of heart failure, came in with orthopnea, PND, New York Heart Association class 4, and an ASACA. BP at that time was at 8640 with a pulse of 70 beats per minute, was saturating at 92% on room air, and was tachypnic at 30 breaths per minute. Also had this cold and clammy, markedly edematous lower limb, with a pacemaker heart rate was at 60. So this is the ECG at the time of admission. Had a paced rhythm with very broad QRS complex. EF from the echo done was at 20 to 25%. Also the LVID was at 239 mils, for which the normal is about 120. Also had an LV stroke volume of, which was elevated at 40 mils with a normal of which was low with a normal of up to 70 mils. So we admitted for intravenous diuresis and optimization of heart failure with reduced EF. Successful diuresis achieved, but then readmitted over the subsequent 2 months for acute decompensated heart failure. So these are the, sorry, with that case scenario, we'll invite Doc.
Thank you. Kindly just go back to the slide with the lessons to learn. The slide before this. Oh, Judy, you can just, yeah, that one. So these are the things that go through our mind when we're looking at this case. So I'd like to ask, let's start with Dr. Wagana. How do we institute diuresis in such a patient? No, not yet, just, yes. How do we institute diuresis in this kind of patient who is hypotensive, what we call cold and wet? They are overloaded but hypotensive.
This is a common scenario that we come across. The fear is normally that if a patient is hypotensive and I give them intravenous diuresis, I'm likely to drop the blood pressure further, and that is something that we see. So it will also come back in the discussion, but we need to find a way to give diuretics in small doses, preferably prolonged over a longer duration of time, so that it doesn't have a very drastic effect on the fluid status of the body suddenly. So the BP is sustained, and then once you start getting diuresis, you reduce afterload significantly, and then the myocardium is able to give you a better contractility. If the blood pressure is very low, then you need to start inotropes from the outset, because that now gives you a bit more leeway even to give sensible doses of diuretics.
So is there such a thing? Because I mean, I'm here even with my nurses from my clinic in Mwai Kibaki Hospital, and there are some people who we say, hiyo ni pressure yake. They come with a BP of 70/30. Hiyo ni pressure yake. Is there such a thing as hiyo ni pressure yake, or are we making up our own things?
Maybe they are outliers.
It's true, right? Yeah.
There are outliers. If you do the blood pressure of the entire population, there's some people on the tail end and they're fine. But you worry about the mean arterial pressure. If the mean arterial pressure is below 60-65, then you're probably not perfusing properly, and that something should be done about that.
Okay, so even when they have heart failure and they are consistently hypotensive, we should not just ignore that. Is that what we are saying?
Shouldn't. Some of the heart failure patients, especially those with very dilated ventricles, like you saw for this gentleman, may tolerate hypotension much better because it's developed slowly. The BP has gone down very slowly over a long period of time, but they are not still in a good physiological state.
Okay. That's good to note. Now, this goes to both of you. Maybe Dr. Nguka can also chip into this. Both cases that we have seen have had readmissions. The first one was readmitted twice. He was readmitted a number of times. So the first question I would ask is, how do you prevent frequent readmissions in patients with heart failure? Are there things we can do that can help these patients in the future? Not because it also deals with cost. Every time they come to hospital, it's very expensive for them. And then is there a way of kind of risk stratifying a patient before they go to, before they're discharged, in a way that you know this one is a high risk of readmission and therefore I need to do this and this? Is there such a way in which we can classify our patients?
Very good question. So heart failure is a very, very common condition, talking about this. So before, maybe I'll let you, Hilda, do this, but how do you ensure, or how do you risk stratify? How do you make sure your patients are well treated to reduce this kind of events? How do we do this? We do this by having something called heart failure protocols in every hospital. So maybe from the audience we can see how many of the people in this hospital, in this audience, have heart failure protocols in their hospital, because that's really the first thing that you can do, because it helps you know, have you done what's in the book?
Show of hands, heart failure protocols in your hospital that you know you have done and they are being followed, not just the ones in the file. 0, 1. Which hospital is that? Diani Beach. Oh, Diani Beach Hospital. Well done, sir. Well done. Let's clap for that hospital. So, Dr. Gunga, tell us more about this.
So, what this protocol tells us, it tells us you have done what needs to be the minimum that you can do, because people say, oh, we cannot do this, we cannot do this. For example, have you checked this patient's kidney profile, and have you made sure that if it is bad, you have consulted the kidney doctor so they can advise you accordingly? Have you checked their hemoglobin to make sure they are not anemic? Not just the hemoglobin, but the iron levels to make sure they are not anemic. Have you ruled out obstructive things which are easy to treat? Have you made sure before they leave the hospital they have been put on guideline directly? Before they leave that door, you make sure they have at least those drugs on board and they are tolerated. Because some people tolerate them in 2 days, others will take them 2 weeks. But doctors are put under pressure by the patients. Oh, we want to go home, we want to go home. And within a short time, the patient will come back. Yeah. So you want to kind of see if you can follow the guidelines, buy the book, and you see if by following everything, then you reduce the chances. Of course, people who have CRT is also some of the purpose of those guidelines. They tell you, oh, we have recommended CRT on 20 patients. Out of those 20, we have only 1 has gotten it. Then you come to another discussion. How can we bridge this gap? This gap. So those are the purpose of some of these guidelines that you put down to paper and they enable you to track your patients. So it's a very, very good point, but I believe guidelines have come up top in helping reduce the heart failure like that we are seeing, that we are talking about here.
Dr. Garnet, would you like to add something? Thank you, Dr. Ngunga. That was very good.
I think many of us have got the protocols in our heads, and they are not in writing. The problem with that is that it's difficult to audit ourselves. And when we have new members in our team, we also don't know at what level of aptitude they are. So I'm also learning from Dr. Ngunga. I think I need to go and influence that wherever I work.
That's amazing. So I think that's a really good point, and that's a take-home message to all of us. Go back to your institution, make sure you have heart failure protocols. Now that we're talking about protocols, I believe they're multidisciplinary. In this audience, we have nurses, we have diabetes nurses, we have other clinic nurses, we have nutritionists. There are many other people here. And the questions they have are, where do we lie in this heart failure business? So what would you say is the role of the allied health professionals in heart failure management in the diabetes patient?
I'm not sure I like the word allied. I think it's just that we don't really have another word. Yeah. Because the team is only as strong as the components of that team. When we're taking care of the heart failure patients who are admitted, there are aspects of nutrition. There are aspects of salt intake, for example. There are aspects of fluid balance, input, output. How keenly are we evaluating that aspect of patient care? There are also aspects now in the American guidelines is actually an indication to evaluate for depression in the patient, and it has a class 2A indication because patients who are depressed and who are not able to have good self-care, it has a direct impact on their outcome in heart failure management. So when we look at the patient as a whole, then all of us plug in different ways. Now, let me use the word because it's the one we use. The allied professionals a lot of times tend to have a closer relationship with our patients than many times the specialists. So, and they're in a better position to pick up some of these very important aspects of care that often are neglected because of pressure of numbers.
I agree with that, especially the nurses. They usually know a lot of details about the patients that we don't even know. Dr. Ngunga?
Talking about what you are calling allied health workers, actually, world over, the evidence for running heart failure, the best evidence falls in what we call the heart failure nurse-led clinic. So why? Because these nurses have a lot of time, they are very patient, the way you have put it. They are able to call patients, pick calls from patients, and that's all they do from morning, and they know the patients by name. And some of those socio-demographic attributes are equally important. So nurse-led clinics have actually picked up in many, many parts of the world. The nurses are able now to say, refer this patient to Dr. Ngunga for CRT, refer this patient for this kind of treatment, refer this patient for cardiologist assessment because we have done everything but nothing is working. So those are the kind of care pathways that really have worked. However, different countries have different systems, and sometimes there are large challenges in implementing nurse-led clinics in our country. I am not sure if in our country we have any nurse-led heart clinic, but maybe we can learn from the team in the
We
crowd.
can learn from the team.
Yeah, but it's a very, very good point.
Any hospital with a nurse-led heart failure clinic? Any hospital represented here? Not yet, and maybe we have Ministry of Health represented, which is good. So these are some of the things that the NCD department and Dr. Elizabeth and our other eminent guests, they can pick up on this, because it's a very good way of ensuring that our heart failure patients are well taken care of. Thank you so much. So I'd like us to move to the next portion. So Dr. Wagana, please let's continue with the presentation, and we'll keep on discussing after every presentation.
So I'd like to say I'm immensely grateful to the leadership of Kdsg for this kind invitation to participate in this sweet congress. I haven't been to a sweet congress before. It's very delightful. So pearls in management of heart failure and diabetes. Our patients, the patients that we take care of usually do not have a single diagnosis in isolation. So many times when we are managing them, we have to think at different aspects of their care. In the patient that presents before me, if we look at the two different scenarios that we had, we have one patient who comes with a very good blood pressure. Therefore, the administration of diuretics is not limited, and I can be very aggressive in my approach to diuresis patients and get them out of hospital sooner than the patient who presents with a challenge of hypotension. So with the hypotensive patient, as we mentioned earlier, you want to use a smaller dose of diuretics. The patient, that the second case scenario, had a blood pressure of 86/40. So you're very, very cautious indeed. You can start with 1 milligram per hour of furosemide. And the way that I would normally do it is have a diluted solution, say in 100 mLs or in 40 mLs. You can do a 1 milligram per ml or 1 milligram per 2 ml, and use a drip counter or a Soluset to be able to administer the dose that you desire. The critical thing with these patients is that you need to be able to monitor their blood pressure very, very closely. So it is best administered in HDU or ICU, where you're able to have continuous blood pressure monitoring. If you do not have that luxury, you can still be able to do it in a ward, maybe in a side room with a keen nursing team, and check initially in the first 1 or 2 hours the blood pressure, maybe 15-20 minutes, and then you can prolong the interval after that. And usually, if you get to about 4 milligrams per hour of furosemide, you'll be able to have profound diuresis. If you look at 2 milligram per hour of Lasix, that's about 48 milligrams over 24-hour duration. It will normally give you much more fluid output as opposed to giving, say, 40 milligrams OD or 40 milligrams BD. So it's actually quite a good dose. What do I need to watch out for when I'm using such diuretic doses? Electrolyte imbalance. So you need to have your finger on the pulse of the potassium and the sodium particularly, so that you don't have issues with electrolyte imbalance. Metolazone is particularly useful in the patients whose renal function is borderline and they are not responding very well to diuresis from loop diuretics, and it gives a complement. Inotropic support, I don't know how many of us have access to this, but norepinephrine or noradrenaline, you can start at 0.2 to 1 milligram per kilo per hour, and then you titrate the blood pressure. Dopamine is preferable over dobutamine, but the caveat with dopamine is that you do not want to go above 10 micrograms per kilo per minute. If you're doing dopamine above 10, then you stand the risk of having peripheral vasoconstriction that is significant. Dobutamine is useful, but problem with dobutamine is that it also causes a degree of peripheral vasodilatation. So especially if you're using it in isolation, you may initially have
should not die.
Electrical kind of circuit to be complete. So the lateral part of the heart contracts much later compared to the septal part. Again, you may have an issue with this video, still not played. Let me see. Oh, there you go. This one has played. So what you see in this video is that the heart is contracting in a desynchronous fashion. If you look at the lateral wall, is contracting, but the septum is going in the opposite direction. When you have that kind of contractility, then you lose what we call the effective cardiac output. Ideally, the heart should contract as 1 unit to enable the blood to get to go through the aorta to increase the cardiac output. So whenever you see this is the hallmark of dysynchrony. There are many types of dysynchrony which occur in heart failure. I tell you one of them is
atrioventricular dysynchrony, like the one Dr. Wagana talked about. That means the atria and the ventricle are doing different things. Is the first part of dysynchrony. The other one we talk about is interventricular dysynchrony. The right ventricle and the left ventricle are working in different fashion, and they are fighting, and that also makes cardiac output worse. And the common one we talk about in heart failure is intraventricular dysynchrony. All these forms of dysynchrony can be treated commonly using a pacemaker. The pacemaker I'm going to talk about is a standard pacemaker. One of them is called a CRT, where you put 2 wires. One goes to the atrium, another one goes to the ventricle, and the third wire goes through the coronary sinus, the lateral wall of the left ventricle. And when you do so, you are enable the heart to contract in unison, in synchrony, to treat what we call dysynchrony. If you look at the picture on the right, you will find that apart from putting a wire in the coronary sinus, you can actually direct that wire to the septum, and you do what we call left bundle area pacing. That's a different technique of pacing which is coming up strongly as a newer technique, because actually instead of using 3 wires, you can actually use 2 wires, and is a better technique in treating patients with heart failure. I will go quickly through the studies which have shown the benefit of this kind of therapies in thousands of patients, and these studies are relatively old, but you will bear with me, there have been no new studies or new equipment which has shown to be superior to this. These studies were conducted in the early 2000s. They looked at patients who have dysynchrony, and they were all have an EF of less than 30%, as happened in the patient that was presented by Dr. Wagana. And these patients were given a CRT or an ICD only. What was found is that the patients who got the CRT did much better. That means the probability of survival for heart failure were much higher, those who got CRT plus ICD compared to ICD only. An ICD is a device that only treats abnormal heart rhythm. That means the tachyarrhythmias or indeed the bradyarrhythmias, whereas a CRT improves synchrony. If you look at this particular study, it is very, very important to note that the patients who benefited are the ones who had a left bundle branch block. So why am I talking about this? Because in a study that we conducted actually in the whole country, we found that amongst the heart failure patients, approximately 10% of them have what we call a left bundle branch block. And these patients who have a left bundle block, if you put a CRT, they can do much better. It does not benefit patients who have a right bundle branch block as much in an LBB patterns and what we call intraventricular conduction delay. So it is imperative to notice that group of patients because they benefit the most from this kind of devices. This study called the Mandate CRT study was followed up to 6 years. The initial study was only 2.4 years, and they showed a massive benefit. They followed up these patients to up to 6 years, and the benefit still persisted. And this is all-cause mortality. The death was much less in this group of patients who got a device compared to those who did not get it. What about non-fatal heart failure events? That means patients who get admitted to the hospital because of heart failure, they keep getting kidney dysfunction. Basically, other events which take place, they are much less in the patients who got the CRT. So if you look at this graph here, the patients who got a CRTD got less than around 10-12% events compared to the ones who got only an ICD with almost 40% events over a 6-year period. So the Mandate CRT study was a big study. It looked at big dimensions. ICD therapy in patients with chronic ischemic heart disease improved survival, but were the same patients with increased risk of heart failure events. Over and above that, it is important to note that the ICD itself, in this study called sudden cardiac death heart failure trial, reduced mortality by 23%, and that's why it remains an important device in giving patients who have heart failure. And that was shown actually in our study in the hospital, again showing the patient who never got ICD, mortality was much higher, although other factors came into play. So this is a study also called the companion trial, showing a 20% reduction in the risk of all-cause mortality or first hospitalization with a CRT in combination with optical medical therapy compared to optical medical therapy alone. So CRTD saved lives in New York functional class 2 to 4 heart failure. These are the very sick patients, and sometimes these questions come into play. Should you put these devices in these very sick patients? The bottom line, these are the ones who benefit the most. Those patients we are seeing are very sick, blood pressure is 80/40. Those are the ones who benefit the most from these devices. What about CRT in New York functional class 1 and 2? This is a very common question, and we cardiologists are posed with this question once in a while. These are patients who are not very sick. How do we know if they require a device? This study was called the reverse trial. Can you reverse remodeling? And it is true in patients who have mild to heart failure, New York function 1 to 2. These devices can also be useful, and they get a 2A recommendation in the guidelines. I will talk a little bit about left bundle pacing because in this particular case is a different technique of pacing the ventricle in a patient who has desynchrony. So instead of putting an additional wire in the coronary sinus, you put the wire in the septum, and this enables you to improve the synchrony. What they showed is that in this group of patients who have heart failure, the new technique, what we call the left bundle area pacing, is much better than the traditional technique. We used very solid endpoints to looking at the treatment effect in those group of patients. If you look at the patients who got a left bundle area pacing, the EF improved much more than the ones who got a CRT, who got a coronary sinus lead. What about if you look at the change in LVEF, again much better over the time compared to the patients who just got a traditional coronary sinus lead. Again, change in left ventricular systolic volume, much better in the patients who got a left bundle area pacing. So left bundle area pacing tries to simulate the normal physiology. Instead of putting a lead in the lateral side of the heart, you put it in the normal where the left bundle is. You kind of overpass the blockage, and we find that is a much better technique. 20% implant time. It may be cheaper for Lois Wagana's patient because you can save, because we have found that one of the issues is the cost, and over and above that there is less LV lead failure, and because of better thresholds compared to the traditional technique, and because of this in our hospital we have actually adopted what we call the left bundle area pacing for most of our patients. I think I will stop there and I will leave the room for questions. Thank you very much.
Thank you very much. That is fantastic. So we have had both sides. You've heard about the pill, you've heard about the device. By a show of hands, how many of us work at a hospital that relies on pills for heart failure? Pills. Pills. What were pills? Okay. Devices? Device? Both? Very good. Yes, sawa. So we have a mix in the audience. We have people who use pill only, some who do pill and device, some maybe device only, I don't know. So I'd like you to tell us, what are the considerations? Because at the end of the day, it needs to be very clear to the person who walks out of here. They have the diabetes patient who has heart disease. First of all, at what point do we say, I need to send this patient to the cardiologist, especially in a low resource setting? And then at what point does this patient who has been on follow-up with a cardiologist need a device? So that we have that clear distinction. Let's start with Dr. Wagana, then we move to Dr. Ngunga, then we take questions from the team. If you have questions, kindly write them down and bring them forward. We need 2 more questions, and I'd like a question on devices. I only have questions on pills.
Thank you very much. I'd like to say, Dr. Ngunga, that was excellent. They're very interesting to listen to you. All our patients with heart failure should be initiated with guideline-directed medical therapy from the outset. And then we have considerations on who requires a device. If a patient has got a life-limiting condition that their longevity is less than a year and it is known, then there is no role really for device implantation. in a patient whose life expectancy is more than a year. So they are not having a terminal illness, they're not having severe dementia, those kind of scenarios. And they are not responding to guideline-directed medical therapy. If the ejection fraction is less than 30, and how do we say they are responding or not responding? Ejection fraction less than 30, they remain in New York Heart 3 or 4, despite optimal management with guideline-directed medical therapy. Or the hypotension limits your ability to scale up their doses to guideline doses, then you need to consider to refer this patient for an ICD. If the QRS duration is more than 130, then that patient should have a CRT. But the discretion whether to CRT or to ICD, I'm sure will be done at a higher level. But you have a heart patient, we used to be told if your patient is giving you tachycardia, you need to think about the next level. So you have a heart failure patient, you're doing what you can, and you're getting uncomfortable, they're not giving you the response that they should have, then it may be time to refer them, unless, of course, they have a terminal condition.
Thank you. Dr. Ngunga?
Thank you, Hilda. Once again, as a person who likes protocols, and I still go back to my heart failure protocol or pathway. So the heart failure pathway is one which tells you who needs a device, who does not. First of all, when you're talking about heart failure, the key to treatment is pills. Pills is number one. Pills will get most of your patients out of heart failure. Probably 70–80% of your patients will do very well with the pills. And we are comfortable when your patients get to functional class 1. Functional class 1 is a patient who has no limitations to activity. If your patient still remains functional class 2, 3, 4 is a very bad group of patients who are commonly in the hospital, sometimes very, very difficult to discharge. Then that group in 2 and 3, that means they still have residual symptoms, and these patients have poor quality of life. Then most of those patients will be candidates for a device. These devices can be a CRT, particularly so if they have a broad QRS, like the what I've shown on that ECG, or an ICD, depending on their risk factor profile. An ICD is a lifesaver. People think it's just a device that we put on patients, and it can stay in maybe 20, 30, 40% of the patients without ever giving any treatment. But it's a lifesaver in another half of the patients who use it, and it does save life. So if patients have EF of less than 35% and they still have symptoms, they may be candidates for a device, and this is usually very well clearly listed in your heart failure pathway that you say the patient has been on. Usually when you give them treatment, you usually wait for around 3 months. Minimum is like 3 months for you to gauge if your therapies are working. If the patients are taking your drugs and it is true they are not improving despite 3 months of therapy, then it means something more is required or something else is causing their failure to improve. And this is where a referral to a cardiologist may be useful. On the other hand, in as much as I know all of us sitting here are physicians, I have had referrals for heart failure patients with all manner of comorbidity. So comorbidities surrounding heart failure may impair your ability to treat them. So always step back and look at the underlying comorbidities which are preventing your heart failure from improving. And sometimes if you tackle those, then you may find your heart failure patient improving.
Thank you very much. We've learned a lot today, including iron. I'm sure some of us have not really been checking up on our iron levels. Now we'll be more keen because now we know that that's part of the tenets of heart failure management. Thank you so much, Dr. Ngunga, Dr. Wagana. I'd like to give you a few questions from the audience. One is, what is the lifespan of the CRT device? And actually, we can just say, what is the lifespan of the devices in general?
Yeah, so a CRT device is put so that it can basically take over the pacing function of the patient. So that means it is required most of it. In fact, when you talk about the efficacy of a CRT device, you must pace at least 97% of the time, because the idea is to correct the desynchrony. So because of that, the life expectancy of a CRT is usually much less, around 7 years. Usually around 7. Normal pacemaker is around 10 to 12 years, but a CRT is around 7 years. On the other hand, if you have the defibrillator only, it has the longest lifespan, because usually it's a watchman device, and if the patient does not get a lot of events, it will just keep an eye and it can stay for between 5 to 10, 20 years. On the other hand, if this patient has a lot of arrhythmias, as we have happened in our case, you can actually deplete that battery in a day if you require 10, 20 shocks in a day, and we have seen that. And we have seen patients die because of failure of a CRT device, which was working before. So if your patient has a CRT device, CRTD, and they get 10, 20 shocks, and they come to the hospital and the device is depleted, and you fail to deplete that device in a short while, the heart failure will progress, and actually you get your patient decompensating very quickly. It's like an acute heart failure event, and the patient can deteriorate very quickly and lead to a bad event. So the defibrillator has the lifespan is not predictable.
Okay, thank you for that. I'll just ask something on top of that, which is if, let's say, Dr. Ngunga, you have placed a CRTD on someone who dies 6 months later, and I have a very sick patient in Mwai Kibaki Hospital, can you have a second hand? Can we borrow? Is that a thing?
So, a very good question, and I like that person's thinking, whoever has asked that question. So, I think around 10 years ago, thereabouts, we got a very good proposal. I think a proposal, it came from, not from Kenya, but the proposal came from Boston, the USA. They wanted to conduct a study on the safety of reusing second-hand devices in this part of the world. That proposal was brought to Aga Khan, KNH, and I think a few other hospitals, but it was rejected at the national level because people just thought they do not want to be given devices which have come from other people, which is a ridiculous issue. However, the study went ahead in other countries. It went ahead in India, I think Bhutan, India, Bangladesh, some other countries, and the safety was demonstrated, and it is true in those countries. Because when the safety has been demonstrated, usually the physician, the doctors are more willing to adopt that kind of approach. But this country, it never took place.
Dr. Wagana has something to say before we close.
Yeah, actually that project is ongoing in MTRH. They got approval and they're implanting those devices. So what happens is that the device is retrieved from the patient who has died, and then it goes through the autoclave or whatever process they use, and then it can be used on someone else.
Okay, great. Now the last question, then we close. When should SGLT2 inhibitors be initiated in acute decompensated heart failure?
SGLT2 inhibitors should be initiated initially, at the very outset. The only caveat is if a patient is severely hypotensive, because they do drop the blood pressure a little bit, in which case you need to wait until you have a good BP, and then you institute. So they should be started in hospital and even in the critical care unit once the blood pressure is okay.
Fantastic. Thank you so much. So let's give a round of applause to our talk, Dr. Judy Adiega, Dr. Wagana, Dr. Ngunga. Asanteni sana. I think we've learned a lot. Asante. So, yes. So I know there are more questions. Oh, we do a photo, yeah? I know there are more questions, but remember they are right here with us. So if your question was not answered, there were many, but we ran out of time. You can always link up with them at any point, and they'll be happy to answer your question. So, okay, thank you very much. Now, before we go to the next session, I just want to remind you there's something like this in front of your table. It has a QR code. Please scan it and be part of the survey that is currently being undertaken for healthcare practices, healthcare provider knowledge, attitude, and practices regarding diabetes management. Thank you, and I'll hand it over to the moderator of the next session, Dr. Shilpa. Who is the... Okay. Oh, it was still me. Sorry. I thought it was next. So we'll move on to the next session. So at this point, I'd like to invite a doctor that we all know. He's going to speak. The next session is about a cardio perspective of GLP-1. So this doctor is a well-known doctor. I think you all know him. Very active, very lively, Dr. Eric Njenga. He's a physician and endocrinologist based at Aga Khan Hospital. So karibu daktari. We're looking forward to see what the GLPs will do to us. I know many of us have heard about this drug from Oprah. Now let's hear it from Eric. Thank you.
So thank you, Hilda, for that kind introduction. So I'm standing between you and lunch, so we'll try and make this as fast as possible, hopefully as short as the half-life of GLP-1, which is 2 minutes. So this will be the focus of our topic today, GLP-1 friend of foe. And since we're in the cardiology panel or session, we're going to just focus on the insights into their cardioprotective effects. And we'll have other lectures focusing on other aspects of GLP-1 use, which are coming up. So that'll be the outline of our talk. Sorry. We'll look at the cardiovascular risk burden in diabetes. We'll have an overview and some historical and current insights on GLP-1 molecules. And we'll have a brief insight into the cardiovascular outcome trials for GLP-1. And we'll look at the combination therapies now emerging with clinical data and also future prospects. So we all know diabetes and cardiovascular disease is something that's, as you've seen from this particular panel, is quite common. So there's actually a 2 to 4 increased risk of morbidity and mortality in the setting of patients who have type 2 diabetes and heart disease. The chance of dying from heart disease, as you can see, is a staggering 60% if you have type 2 diabetes. And also you can see, that there is a 2 to 3-fold increased risk of developing heart disease in the setting of diabetes. Now remember, this is all clinical data as compared to age and sex-matched non-diabetic cohorts. So that's how important it is looking at the risk factors of heart disease in the setting of diabetes. Now, because of this, there is a reduction in lifespan by approximately 19 years in this particular patient. The commonest cause of death, up to 70%, is atherosclerotic cardiovascular disease. And as you can see there, these events occur 14.6 years earlier, once again, if you compare them to your patients who are 40 years and above, who are non-diabetic. So again, very, very important topic, and that's why we spend time to our panel of cardiology experts here to try and talk about this very important comorbidity in the setting of type 2 diabetes. So what are some of the historical perspectives? Where did it all start? And it all started with a gut feeling. So Labarre and Steele were first able to identify that an insulinotropic gut hormone in the year 1930. Then GIP itself was identified as a distinct molecule in 1971. And then we had GLP-1 now, which was now discovered in the year 1971. And identification distinctly was in the year 1983, as you can see there. And looking at nature, we actually have origins of this particular molecule, and this is the Gila monster, as you're all aware, where the first extract of a structure which was homologous to human or native GLP-1 was actually extracted in the 1990s, and this was called exendin-4, and it does exactly the same thing that these incretin molecules do in our bodies, which is to stimulate insulin secretion as well as inhibit the release of glucagon. So we have two distinct molecules. Where we have glucagon-like peptide, which is produced by your L cells, and it stimulates insulin release. It's the more potent molecule as compared to GIP. Then you have your glucose-dependent insulinotropic peptide, or gastric inhibitory polypeptide, which is 10 times higher in terms of its levels, but it's not a very good therapeutic target in the setting of type 2 diabetes because most patients with diabetes tend to be more resistant. Now, these two incretins account for 70% of your insulin production, and they account for what is called a very robust fast-phase insulin response from your pancreatic beta cells. But what happens in the setting of type 2 diabetes, as you can see, the incretin effect severely blunts, because of the reduced level, the fast-phase insulin response with reduced insulin production. So there are several GLP-1s, and we'll ask ourselves, are they all the same? So just looking at their structure, they tend to differ with regard to their homology to native or human GLP-1, as you can see there. There are some which are very close, like liraglutide at 97%, together with albiglutide. Semaglutide has a 94% homology with native GLP-1. So they tend to differ in terms of their chemical structure, and these differences are mainly attributed to substitutions of amino acids or addition of side chains, which could make the molecule either have a longer half-life or more stable. Let's look specifically more at semaglutide, what makes it distinct as a molecule. 3 key areas which are actually altered in the chemical structure. We have a substitution occurring at position 8 of arginine. Then we have the addition of a spacer and a fatty acid diacid chain occurring at position 26, which makes it bind more avidly to albumin, therefore making it more stable and giving it a longer half-life, hence why you can inject it once a week. And then lastly, at position 34, as you can see there, you have another amino acid substitution that gives it its unique structure and chemical properties. So as you're aware, the GLP-1 receptors are widely spread throughout the body and they tend to have multi-systemic effects. At the pancreatic beta cells, they tend to provide an increased fast-phase, a robust fast-phase insulin response that's directly on the effect of the pancreatic beta cells. Your delta cells, as you can see there, they increase your somatostatin levels and they inhibit your glucagon production. They inhibit gastric emptying time. They have effects also in the liver, where they actually have effects in reducing hepatic steatosis. And in fact, this is a very huge topic in the gastro world now, looking at clinical trials with GIP and GLP-1 emerging prospects, now looking at fatty liver disease. Similarly, how we have the SL2 inhibitors, which have been shown to have benefits in the setting of hepatic steatosis as well. And you can see all those other systems where we tend to have effects. At the level of the endothelium, you have decreased inflammation with antithrombotic effects. At the level of the central nervous system, there's reduction in satiety, averseness to food is increased. Level of the kidney, you have a reduction in albuminuria with kidney benefits, and also cardioprotection at the level of the myocardium. So let's zero in specifically on what happens at the level of the myocardium for the cardiovascular benefits. So you can see there, there's decreased inflammation of the myocyte itself. You have increased glucose uptake, reduction in ischemic injury, and improvement overall in left ventricular function. At the level of the blood vessels, you have a reduction in your endothelial inflammation, vasodilatation, and improved plaque stability, as well as reduction in your smooth muscle proliferation. So that's how the overall cardiovascular benefits for the GLP-1 analogs are seen, and that's how they derive the benefits, as we'll see in the clinical outcome trials. So even the effects vary depending on whether you have a healthy heart in the setting of the ischemic heart, in the setting of myocardial infarction or post-myocardial infarction, and again in the setting of heart failure, which we said is common in our patients who have type 2 diabetes. So as you can see there, focusing on the diseased state heart, ischemic, and the failing heart failure itself, there's an improvement in coronary blood flow, improvement in your left ventricular ejection fraction, as well as improvement in your myocardial salvage index in the setting of post-myocardial infarction, and a reduction in your overall infarct size. Again, at the level of the myocardium, there's improved oxygen consumption and also a more efficient use of energy at the level of the myocardium, therefore improving overall myocardial contractility. So let's now just have an overview of the outcome data, and we have several clinical trials. We have those, for example, that are completed, for example, SUSTAIN 6 with semaglutide. We have the Pioneer 6 studies, which are inferiority studies, so some are superiority and some are inferiority studies. We have, for example, abiglutide, which is a superiority study, looking at the benefits in terms of 3-point MACE reduction across board. Then also we have studies that are still ongoing. For example, SOUL with semaglutide, which is still ongoing, and we'll look about the combination molecules with GLP and GIP, tirzepatide, where we have the SURPASS CVOT trial currently also ongoing, started off in 2024 and is yet to be completed. So that's just a snapshot of where we've come from and where we have clinical data from a 3-point MACE reduction perspective for superiority, and where we're headed to in terms of where we're expecting more data to come up in the future. So I'll just briefly summarize some of the key concepts. The landmark trial that actually brought most of the benefits that were seen was the LEADER trial, where we saw a 22% reduction in cardiovascular death, a 12% reduction in unfatal myocardial infarction, as well as an 11% reduction in non-fatal stroke. Similarly, if you look at expanded MACE for all-cause death and other outcomes, 22% reduction for all-cause expanded MACE outcomes. If you're looking specifically at heart failure, there's also improvement with regard to reduction of heart failure hospitalization, very, very key. And also, we have an overall reduction of all-cause death by 15%. So definite benefits which you are very clear with liraglutide, which was the preceding molecule before we got all the other outcome data from the newer agents. Overall reduction, I just want to focus on also improvement with regard to kidney outcomes. You can see over 22% reduction in terms of renal events. And again, we'll focus on that in one of our sessions in the conference, looking at the benefits of GLP-1 in the setting of chronic kidney disease. Dulaglutide is another molecule that has use, especially in the setting of advanced chronic kidney disease in the setting of type 2 diabetes. And as you can see there, for 3-point MACE outcomes, it did show statistical significance with a p-value of 0.026. And again, if you look at your expanded microvascular outcome, specifically look at renal and eye events, there's also a reduction with a p-value of 0.02. So definite benefits from a macrovascular perspective of these particular molecules, and benefits also from a microvascular perspectives as demonstrated by these two landmark clinical trials. And that was the landmark trial. Now looking at the newer molecules with the newer data we got from semaglutide. So again, overall 3-point MACE reduction was seen with this particular molecule, where we had an overall 26% reduction with regard to your 3-point MACE outcomes, and also improvements with regard to A1C as compared to placebo, and also improvement definitely, as you're aware, with weight in this particular cohort of patients. And the improvements are seen with higher doses of semaglutide. So if you use higher doses, 0.51 milligram, your reduction in A1C as well as weight is actually seen to be more beneficial in comparison to placebo. What's the difference with regard to now oral? That was injectable semaglutide. What's the cardiovascular outcome with regard to oral semaglutide? So sadly, this did not reach superiority for 3-point MACE outcomes. As you can see, the p-value there was 0.17. So for oral semaglutide, no cardiovascular risk reduction is seen. But if you look at the other outcome data in terms of HbA1c reduction and weight loss, then the benefits are there. So this now restricts the use of this particular molecule for your patients who you want to just derive benefits of weight loss, but you're not targeting to bring down cardiovascular risk. So it would not be an ideal molecule to use in your patients who have type 2 diabetes or with high cardiovascular risk if you want to have the benefits of cardiovascular risk reduction. Those who are non-diabetic, planning to lose weight, then it's an option for those who don't want injectable therapy in that particular group of patients. So how do we position them? As per our guidelines, which have been revised from 2018, with now all the CVOT outcome trials influencing how we look at positioning molecules in the setting of diabetes. So very, very clear. Your patient with type 2 diabetes with a high cardiovascular risk will benefit. Your patient with type 2 diabetes with a primary cardiovascular event, stroke, myocardial infarction, or peripheral vascular disease is definitely someone you should consider. But if they have chronic kidney disease and heart failure, we definitely know there's overwhelming evidence to now institute the use of SGLT2 inhibitors in that particular group of patients. And of course, your patients who have type 2 diabetes, where you're now targeting weight loss as a key target in your treatment outcomes, as well as trying to minimize the risk of hypoglycemia in your patients if you want to consider additive add-on regimens to either to insulin or to your other oral therapies. And this has been adopted by all the leading clinical societies, the ACC, American Heart Association, the ADA, American Association of Clinical Endocrinology, as well as the American Stroke Association. So that's an overview of how you initiate these particular molecules. The key thing, start slowly. For example, semaglutide, initiate your dose at as low as 0.25 milligrams for at least the first 4 weeks. Then you can up titrate to 0.5 milligrams for the next 4 weeks, and gradually move up to try and target the maximum dose, which can be either 2.4 milligrams or 2 milligrams, depending upon the specific formulation for your pre-filled pens. For liraglutide, you can begin at 0.6, gradually up titrate by 0.6 milligrams up to a maximum of 1.8 milligrams, but it's a daily injection. Hence the reason why most of us are shifting towards weekly injection. It's more convenient for the patient to inject once weekly because of that unique side chain addition that we saw at position 26, which makes it have a longer half-life, and therefore you can use it comfortably with the same benefits at once a week dosing. So key thing, start slow to avoid some of the side effects we'll talk about for this particular molecule. Again, there are benefits, as you've seen in the setting of chronic kidney disease, but once your patient gets to end stage, there'll be no benefit in continuing these particular molecules, unless probably you're just targeting weight loss. But Dr. Soki will give us a talk about the utility. But if someone is in end stage, there's not much you're going to achieve. But you can see you can go down to as low as an eGFR of 15 minutes per minute for both liraglutide as well as semaglutide. So key things to consider. If you have other add-on therapies, you remember to withdraw your DPP-4 inhibitors because they both fall in the incretin class. So if you're on any DPP-4 inhibitor and you're adding this as add-on therapy, you withdraw your DPP-4 inhibitors. Side effects, nausea, vomiting, diarrhea, bloating, you must warn your patients about these side effects as you start off. That's why we start slowly, up titrate gradually. There are those who may not be able to go up to those high doses. In fact, what we clearly see in clinical practice is a lot of people are not able to tolerate doses beyond, the 1.5s and the 2s. Very few patients in the African cohort. We don't have studies, but what we see in clinical practice. But surprisingly, in the West, you have a huge number of patients who are up-titrated up to 2.4 milligrams with a lower side effect profile. But it can be very challenging to have someone on 2 milligrams. So you have to counsel them well with regard to what to expect. So like I said, again, also techniques of injection, safety of the injection sites, how to ensure that there's no local infection. Same way we give instruction on insulin use. And in fact, when we see them in the diabetes clinic, our nurse educators train them. They've now been trained on how to use the pre-filled devices, and they actually train our patients how to inject, similar to how they inject insulin. It's very easy. They can do it by themselves. So again, even for people who are not diabetic, just coming in for weight loss, the training is quite easy and they can inject themselves once a week. You don't need any baseline tests for anyone who's just coming in. Forget about this cardiovascular space. But for someone even coming in just for weight loss, you don't need to check their pancreatic enzymes or liver enzymes periodically, but do expect a transient 20% increase in their pancreatic enzymes, but it's nothing to worry about. Just a few precautions that we'll have. Key things, watch out for anyone who's had acute or chronic pancreatitis, any history of medullary thyroid cancer in the family for a first-degree relative, or if you distinctly look for any particular features of MEN2A syndrome, try and avoid the drug. Of course, in the setting of people who have type 1 diabetes, not advocated for use, preconception, pregnancy, acute diabetic emergencies like diabetic ketoacidosis, hypersensitivity, try and avoid it. Compelling indications, weight loss, looking for add-on therapy for HbA1c lowering, which has low risk of hypoglycemia. Be cautious, like we said, in the setting of advanced kidney disease. If they're going down to end stage, you have to stop the drug after eGFR falls below 15 minutes per minute, and also moderate to severe hepatic impairment. Monotherapy for those who are metformin intolerant, if you're just targeting obesity as a treatment target, and of course those groups of patients who would benefit in terms of atherosclerotic cardiovascular risk reduction. You can use them as add-on therapy for dual or triple therapy, but remember to withdraw your DPP-4 inhibitors, and they can safely be used with as core formulations, or even distinctly with basal insulins like glargine. And we have combinations, and we'll look at that shortly with regard to where we're headed in terms of how we package these particular molecules. So adverse events, we've covered that. So key things, just how you counsel the patient. So remember, just warn them. After your first injection, probably just do it on the weekend when you're at home. Don't inject yourself and then take a flight from here to Atlanta with a window seat. So just advise them. They're going to have problems, okay? So nausea, diarrhea, vomiting, inject, stay at home for a couple of days. Then now you can be able to see, will I be comfortable working this week? So don't come for a board meeting, or you're coming in for a long conference and you're injecting on the same time. Just advise them that. It's good to tell them, expect the nausea, expect the bloating, expect the diarrhea, it's going to happen. Normally it gets better with subsequent doses, and as you titrate the doses slowly upwards, you tend to have the side effects occurring less. But there are those who can have very, very severe effects, and you have to withdraw the drug, and you may go up to a higher dose. They can't tolerate, just go back to the preceding dose and keep them on that, okay? But counsel the patients about these particular side effects and how to deal with them. You can give your PPIs, you can give your antiemetics as add-on when you're actually starting these particular drugs. If people already have pre-existing, for example, gastritis, gastroesophageal reflux disease, so try and at least give them other additional drugs to try and prevent those side effects from getting worse. And again, the usual counseling for how to inject, how to take care of the injection sites is also very, very key. Cold chain, very, very important as well. So we have a lot of patients who are coming to us from Congo, even West Africa, Somalia. They're coming in buying a 6-month supply of these drugs. Very important to maintain cold chain throughout, okay? So as you prescribe a huge batch of drugs for someone traveling, remember to issue a travel letter for them to be cleared through customs. So very, very important that you must have a template of a travel letter to give your patients. Now the drug itself can be outside at room temperature less than 20 degrees for at least a month, but after that it's no longer viable. So whatever you're not using should be in the fridge between 4 to 8 degrees. So that discussion has to be had with the patient so that you don't buy a huge stock and the efficacy is lost because of the cold chain is damaged itself. Even with regard to how these drugs are imported, it's very, very important. You've had now there are parallel imports of semaglutide, and we don't know about whether the cold chain is actually preserved. So again, we need to be very, very, these are very expensive drugs. So if people are paying this amount of money for these expensive drugs, the PPB and other regulatory bodies have to ensure that cold chain is maintained throughout. Expectations. So it's looked at as a wonder drug, magic bullet for weight loss that you can eat how you want, do whatever you want, but just manage expectations. So let people not think that they're going to be 150 kilos and in 2 months they'll be 98, okay? Just manage expectations. Give them a realistic figure. You'll probably lose 2 kilos a month. At least if you tell them that in the next 3 months you've lost 10 kilos or 8 kilos, it's a bit realistic. If they surpass, well and good. They come to the clinic, they surprise you, you high-five each other, well and good. But don't give them huge weight loss, because you know it's expensive. They will expect I will invest for 3 months for this particular drug. Then if I only lose 4 kilos or 2 kilos, they get very discouraged. So some people do go on these drugs. Initially, they don't lose a lot of weight. Remember that the weight loss is achieved with the higher doses, the 2 milligrams, the 2.4 milligrams. At the 0.25, you're not going to lose much weight at the 0.5. That's why we try to gradually up-titrate the dose. The higher the dose, the better the A1C lowering, the better the weight loss. Remember that, okay? But try and manage your expectations. Let them go through our weight loss program. Involve your nutritionist, your counselor. They still have to exercise. Remember that. So it's not that I'm going to inject, I will lose weight. If I don't exercise, if I don't eat healthy, remember you're not going to have a very downward trend with regard to your weight loss. Again, also, the drugs are quite expensive. So realistically, am I going to use the drugs for 3 months or am I going to use the drugs for 6 months? So I can budget. So who knows what the cheapest GLP-1 right now per month costs in the market? As a show of hands. Cheapest. 25,000. So it's 25, 20,000. That's the cheapest. 20,000 per month. Now, for people in the county, how many patients can walk in and afford 20,000 a month? Even in private practice, it's quite expensive. Now, Ozempic is the original molecule. Guess how much it costs in Aga Khan? Just by a show of hands. Take a wild guess. Ozempic, original, ile ya Oprah. Bado. Ati 80? Hiyo ni kidogo. Cheapest. Hiyo ni kidogo. Average minimum price for the lowest dose in Aga Khan is actually 200,000. If you're on the higher dose, 256,000 per month. 256,000 per month. The minimum dose in Aga Khan is 200,000. So that's how expensive it is for the original drug. But the good thing, we have a lot of generics now in the market. So like I said, because the drug is injectable, remember, they can safely be combined with your basal insulin. And we do have core formulations, as you can see, like Ideglira, or you can combine lixisenatide with insulin glargine. You can see the various combination ratios there. They are safe to use and also have been approved by all the regulatory bodies. So again, they are good add-ons to your basal insulin regimen therapy, because number one, you get better A1C lowering with this drug as an addition. You get weight loss benefits and you have low risk of hypoglycemia. So a very good option, if affordable, to combine to your basal insulin. Okay. So if you're going to now look at combined GIP and GLP-1 targets, and that's now tirzepatide, and that's now the most recent data that we actually have. So you have now 2 distinctive arms which have now 2 distinct molecular pathways, where you have 2 pathways now stimulating insulin release, suppressing glucagon, decreasing gastric emptying time, having effects on your central nervous system as well as your ectopic fat production. And as you can see now, if you use both pathways, it's much more superior, especially at higher doses, head-to-head comparison with semaglutide. So it is a superior molecule in terms of weight loss, A1C lowering, but has no data on cardiovascular outcome trials as of yet, okay? That's the next space that we are headed to. So what's the future therapies? So one is now GIP receptor agonism, other distinct targets, rather than looking at a combination. So we could have other molecular targets, other new drugs targeting this particular receptor. There's also glucagon receptor agonism is now a new concept, because this actually has anti-obesity effects and improves your energy expenditure. So that's a future target that we're looking at. And there's something now called triagonism that people are looking into, where you target the 3 receptors, GLP-1, GIP, and your glucagon receptor all concomitantly. And now there are clinical pathways for phase 1, phase 2 clinical trials looking at targeting those 3 distinctive pathways as a mechanism of achieving A1C lowering, weight loss, as well as reduction in cardiovascular outcomes. So this is why we all started off. The wonder drug that moved Oprah Winfrey from there to that stunning figure. which I've been staring at for some time. And she looks several years younger. So I think she's been a brand ambassador. I think Novo Nordisk team, I think she must be on your payroll, Novo Nordisk, if you're here. Yeah? If you look at their books, man, I think there's a lot of money going to Oprah. She's really marketed this drug. Every woman in the world knows about Ozempic. Yeah? So what are the things to think about? Use in type 1 diabetics, remember that there's actual clinical data in the setting of type 1 diabetes with both exenatide and liraglutide. We have data released from 2019, but you have to target people who have type 1 diabetes in a clinical trial setting, who have detectable levels of C-peptide, are not achieving their targets on injectable therapy, and also are obese. But again, remember, it's a controlled clinical setting, similar to what we do with regard to SGLT2 inhibitor use in the setting of type 1 diabetics. They must be in a very controlled environment, but not FDA approved in the setting of type 1 diabetes. So very, very important, but it's a space to look out for in the future. Screening for men, just take a good clinical history to look for features of men and ask for history of medullary thyroid cancer in any first-degree relative and avoid the drug in that particular setting. And of course, acute and chronic pancreatitis. The big question is, how long should we keep patients on these drugs? We don't know. There's no outcome data saying that people have been on a clinical trial follow-up, they've used the drug for, let's say, a year or two, stop the drug, do they get rebound weight? We don't know that. There are questions. Do you get worse rebound weight if you stop these particular drugs? That's a huge question we're getting nowadays, but we also don't know. So that's why we're going to look at the next phase of clinical trials to answer the question, are these drugs lifelong or do you use them for a set period? Because they're very expensive, what we say is, let people plan. You budget for 6 months, I'm going to do 20,000 times 6, that's 120K to lose X amount of weight. Be realistic. When I stop, at least attach them to a good program with a good nutritionist. They must exercise. Let them be motivated, get a counselor, so at least they can be able to keep that weight off after they've achieved their target. Most times, if you come from 120 kilos to, let's say, 108, you'll be very happy and you'll be motivated to do something, as opposed to just moving from 120 to 118. So if the drugs work, someone gets motivated, they lose weight, people feel good about themselves, you're more likely to adopt a healthy lifestyle because you've seen the benefits of losing weight. So that's the key thing, and that brings me to the end of my talk. Thank you.
Wow. Thank you, Doctor. No, wait, where are you going? Kwanza, I have a very heavy question for you. Kaa kwanza. Just sit. This is a very, you need to sit. But first of all, he has given me a business idea. I'm going to open a pharmacy right opposite Aga Khan. Nyinyi muambie 200K, mimi niwaambie come. Now, this question is very interesting. Are you ready, Eric? Given that GLP-1 agonists and GIP agonists account for approximately 70% of insulin secretion, and type 2 diabetes is a progressive loss or failure of beta cells, is there a threshold residual beta cell capacity below which GLP-1 agonists will not work? And also, how do you make the determination to stop the GLP-1 agonist versus adding on other treatments when you bear in mind the C-peptide levels? Si nilikuambia?
So that's an excellent question. So we definitely know one thing. Type 2 diabetes is a chronic metabolic condition with progressive beta cell decline. Average loss of beta cell per year is approximately anything between 1 to 4%, which is cumulative. So remember, these drugs, their targets, as we said, are the pancreatic beta cells. So you must know what your baseline. We're not able to test pancreatic beta cell mass. You have to do what is called a HOMA-B index to look at the actual pancreatic beta cell mass. We say realistically that people who are diagnosed with diabetes at onset have lost 50% of their beta cell mass, and they will experience progressive decline, which will vary from person to person based on your genetics. So that's very, very key. So eventually, once you've lost a significant proportion of your beta cell mass, then definitely these drugs are not going to work. So remember that fast phase insulin response is severely blunted because of that low beta cell mass. They do they do slow down the progression of beta cell mass, because one of the mechanisms of how they actually work, I demonstrated, is to reduce beta cell apoptosis. So definitely the benefit is, if you are diabetic, they could actually delay the onset of insulin use, for example, because it slows down the rate at which you have apoptosis of your beta cells. But once you get to a critical beta cell mass value below that, the drugs now no longer work and will not have benefit. And that's why in the setting of those clinical trials with people who have type 1 diabetes, you must do a HOMA-B index and you must look at your C-peptide levels. They must have a detectable levels of C-peptide in the background of type 1 diabetes or LADA for them to be included into the clinical trial. Because most people who have type 1 diabetes have predominant significant loss of their beta cell mass. That's why they go to insulin straight away. So the caveat is there must be a detectable C-peptide for these drugs to work. Eventual pathway for type 2 diabetics is that they will have decline and they will end up on insulin. The drugs therefore will not have benefit in that setting.
Yeah. Thank you very much, Daktari. Well answered. The next question, I would like to hand it to our chair of KDSG. Someone is asking, how do we as healthcare providers stroke KDSG go about ensuring that the GLP-1 analog generics are legit, effective, and safe?
I think effectiveness and safety is found out through trials, and those have been done. A lot of these molecules they're already at phase 3, phase 3B, and those are done. I think in terms of what is brought in and legitimacy, there's the PPB. We are not a regulatory body as KDSG, but the Pharmacy and Poisons Board is mandated as a country to regulate what is coming into the country. And I think there is the role of the companies that produce originals working together with us as healthcare providers to ensure if we find molecules that are not working, we can report them, and there is a mechanism. So KDSG is not a regulatory body in that sense, I think.
Yeah. Thank you. So PPB is where we go. Dr. Saira?
No, I'm just adding to that question that Dr. Eric answered with beta cell mass. Just to add to that, you know, GLP-1 receptor agonists and your GIP, especially the GLP-1, they have sites or mechanism of actions beyond just the beta cells. So it may still be beneficial in patients who have reduced beta cell reserve, because they still do work at the level of the brain, they still do work at the level
CNS.
of your gastric emptying, and at the level of now looking at the microbiome in intestinal level. So probably the benefits would be there beyond that, but I agree that there are no, I don't think there are fixed studies to show the reduced complete beta cell reserve what to do.
And just to remind us, these are novel agents, which means some of these things we'll just be learning. We are winging it. We'll be learning these things as we go along. So in the next 10 years, now the conferences that are there will be looking back and saying, what has this shown? What has this shown? We'll have a lot of data at that point. The reason why I have invited Dr. Abdullahi,
to add on very, very quickly.
Yes.
Remember, just to add on to that point, so that question specifically was talking about insulin secretion.
Yes, secretion.
But like she said, remember you can have someone with complete loss of beta cell mass, but you're targeting cardiovascular benefit.
Yes.
So again, that's very, very key, as she said on.
And renal.
And
So
renal.
nowadays
so
there's
renal,
a lot of
cardiovascular,
renal.
satiety, and other things.
Yes,
Yeah,
thank
so
you.
very, very important point here.
Thank you. So I've called Dr. Abdullahi on stage to give us a few pearls. He has extensive history of using the GLP analogs, and he wants to give us a bit of his experience, a snippet of what he's gone through. Karibu Daktari.
Thank you very much. I've had the pleasure of using the drug for about a year with my patients. Some practical points. One, you have to start very low and titrate based on the patient's tolerance to the drug. So you can't start at 1 milligram. You have to start low. The second thing is, as Dr. Eric said, is you have to manage expectations of patients. The third thing, I start the patients, mostly the medications over the weekend because of the side effects. Most patients are in blue-collar jobs, so you start them on Fridays or Saturdays, and you see. Sometimes you have to use unconventional doses, not what is recommended there, 0.25, you go to 0.5. Sometimes you use less clicks, so you use a dose in between based on how the patient handles it. And then the other issue, as Dr. Eric also said, is that the patients who get the most benefit in terms of weight loss are the ones who combine together with nutrition and exercise. And now, since March this year, FDA has approved semaglutide's use in patients who have cardiovascular disease and being overweight and or obese. So there is indication beyond diabetes. And now I am using that for patients who have cardiovascular disease and have obesity or are overweight. And it is really, really working. What I've also done is not conventional, but I do baseline tests for these patients before, and I repeat after 3 months. And you can see clearly even patients who have impaired glucose tolerance or who are pre-diabetes, you see that they are reverting. Also the ones who are dyslipidemic, you can see the LDL. Roughly about 20 to 30% drop in their LDL, which is nearly as good as some of the statins or the lipid-lowering agents. So basically that, and I think as the price becomes more affordable, I think it is something that we need to consider for patients. Also, I've had patients who use it as a maintenance drug, unfortunately. So what happens is a patient takes the medication to achieve a certain weight. Then when they get to that weight, they stop, and then they gain weight, then they start using again. So I'm yet to see whether there's any effect beyond that in terms of the rest of their cardiovascular health.
Okay, so just as a weight loss drug, eh? Now, the last question, then we close. Are injectables more beneficial than oral drugs? Now, I will try and think that this is GLP-1 because we have oral GLP-1s. So tell us more about the orals. Are they as beneficial?
So remember, the weight loss efficacy is much, much higher with injectable as compared to oral, number one. And again, the other thing that we've clearly pointed out, you've seen the 2 clinical trials, cardiovascular outcome trials with injectable and oral. The benefit is only with injectable semaglutide. For the oral, like I showed you, the p-value was 0.71. It did not reach any statistical significance. So oral drugs, oral semaglutide, it's only used now in the setting of people now where you're just targeting weight loss who are not diabetic and who don't want injectable therapy, but the efficacy just know is actually lower. So injectable is better from both perspectives. Yeah.
Thank you very much. So we are out of time. As we close, I just want to also finish and say, as we leave here, let's remember, at the basics is a lifestyle. When you're talking about weight loss, lifestyle, diet and exercise, that is the number one. GLP-1s are there, but like Dr. has said, and I've seen it in my practice as well, you give it for a time and they will gain weight again once they stop the drug. They have to change their lifestyle. Extremely important. So thank you so much. Oh yes, Dr. Njenga, final words and then we close.
Yes, good. So we're out of the scientific session. I just want to make one very, very important announcement because this is the biggest number I think we'll have at any one point. So I just want to tell you in terms of this now doctors' welfare and all cadres of staff. So we have, as KAP, I'm president of the Kenya Association of Physicians, and one of the key mandates that we have is to try and improve welfare for our doctors. I just want to borrow 2-3 minutes. We have 2 companies who are actually our sponsors, and I want to invite just 2 minutes. One person will speak on new products we are going to have. So right now we're running an international medical scheme, BUPA, for doctors. But as of this year, we are now opening up to nurses, clinical officers, and we are going to have local insurance packages, which will be subsidized because we are going to pool you as a group for as low as 15,000, okay? So I just want Sabir just to stand up. So we have a booth there. So please, as you're looking at other vendors, anyone who is interested in signing up for insurance, health, medical insurance, doctors, indemnity, critical care, illness, and this can be packaged together, then kindly see Sabir at the stage as well as Zamara. So thank you so much.
Thank you. Okay, so as we close, I have a few announcements. Let's clap for Dr. Eric Njenga, and thank you, Dr. Abdullahi. So a few announcements. One, there is a Kdsg booth. Who has gone through the Kdsg booth? Who has registered for Kdsg? How many people here are registered members? You see, we are still less than a half. So kindly, if you know you're here, it means you can be a Kdsg member. It is not for doctors, it is not for nurses, not for nutritionists, it's for everybody who takes care of a diabetes patient. So please